morning, everyone. You guys hear me okay?
Yes.
Okay, perfect. All right, so we got a couple more minutes before we start officially, so I'm waiting for people to get in here. So carry on with whatever you were doing for a few minutes, and then we'll get started. All right, I'm just gonna start, even though it's 8:29. Whatever, people will show up if they show up. Good morning, everyone. I'm Mrs. Silk, so if you haven't met me before, this is me. um, So today we're just going to go ahead and, look through the syllabus and look through the addendum and those types of things, make sure that everyone's on the same page with what's expected of them. And then we'll get into a little bit of content at the end. So I have my syllabus pulled up here, so we'll go ahead and start with that. So I have obviously I'm not at the school, I'm at home, so this is my office extension at school. But I'm going to go ahead and give you my cell phone number just in case you need me for something. So you could write that down and that way you have it. So my cell phone number is 330-256-4043. So if you need to text me about something, you can do that. Obviously, first preference would be email, but if you need something, you could get a hold of me the other way. Go ahead and look on this right-hand side of the screen here. So this is what my schedule looks like for the week. So Mondays, I don't have class. So what I do is I do a virtual day on Monday. So what that means is I'm available pretty much 8 to 4, but by email. So if you need me for something, you could get a hold of me that way. Tuesdays, I have your class from 8:30 to 11:30, and then I put office hours kind of directly after class. So 12 to 2, and I did that both on Tuesday and Thursday. So that way, if you guys need something, we can meet together after class. Wednesdays, I have 2 classes. So I do one in the morning from 8 to 11:45, and then another one from 12:30 to 3:20. So I'm kind of, done for the day on Wednesdays. And then Friday, I have a class from 9 to 11:50, and then I do a lab from 12:30 to 3. So that's kind of what I'm doing for the week. At the bottom here, I put you guys as clinical instructors. So Amanda Joseph is here. Here's her email address and her phone number in case you need to get a hold of her about anything. I know the group already had her yesterday for clinical, so that's her. Samantha Zellhart is another clinical instructor. She's doing 2 groups for me this term. So I know one of her groups went yesterday and another one goes Wednesday. But here's her stuff. So she works at the VA, so I have both her Herzing and her VA email addresses there just in case. And then here's her phone number. And then Olivia Jones is going to be a clinical instructor for us for this term. She is, well, anyway, here's her email address and her phone number. And then Molly Pittman is the last one. So she's down here at the bottom. Okay, so going on. So I don't know if you guys have ever bothered looking at this on your syllabus before, but where it says credit hours and contact hours, it talks about like how many hours you're supposed to have for clinical. So where it says internship, externship, clinical, practicum hours, it's 45 hours. So with these stupid VSIMs that we do, which I know not everyone likes them, I get it. I'm getting really sick of them myself, but that's what we have for now. So that's what we got to do. But anyway, I sent a thing to all the clinical instructors about kind of the breakdown of time for each thing that you're supposed to do for clinical. And it's pretty close to this. It came out to like 44.5 hours or something like that. So it's pretty close. All right. Then keep going here. All right. Here's our textbook. So we have Hinkle and Cheever. It's the 2017 version, 14th edition, and it looks like this. So it's kind of like a pinkish purplish color to it in the front. So I know most of you have ebooks, but sometimes people will get the actual book. I had a student a couple terms ago, he was looking for it online or something, and what he found was that they break this into 2. So instead of having this big, huge book like this, they break it into 2 volumes. And so it's the same thing, it's just 2 volumes of the book. So if you ever wanted to get it, you could. This is going to be the same book that you use for Adult 2 and also the same book that you use for Adult 3. So it's an important book. So you're going to want to keep a hold of it for a while. Other things, can you guys tell me, did you get an ATI book in the mail just recently for MedSurg?
Yes.
Okay, perfect. So it should be purple. So it should look kind of like this. Did you also get a green ATI book?
Yes.
Okay, so that one would be like this.
Nutrition, right?
Yes, and it's real thin. Good. I was hoping she sent that. I talked to the dean, before the term started, and I wanted her to send both of those out to you guys. So technically, we don't really have a nutrition class per se. So we give this to you kind of early on because when you, I don't know if you've flipped through it or not, but when you flip through it, it talks about a lot of different types of diets and things that are important for you to know. And so, like during the term, we talk about a lot of GI stuff, and there's some stuff in here that would be really helpful for you to have. So that's why I gave it to you now. So those are the books that you should have for this term. Okay, let's keep going here. All right, so for today, this is the July 7th. So again, I tried to be as clear as I could on the syllabus so you know what the heck we're doing every day. So again, we're just going over some of our expectations and our syllabus and all that, and then we'll start in with pre-op stuff today. And you know, depending on how quickly I get through it, if we still have time, I might do something else too. But basically, this first week we talk about pre-op, intra-op, and post-op. So it's chapter 17, 18, and 19 in that big book. So it's kind of, I like this topic. I think it's kind of interesting. I used to work on a surgical telemetry floor, and I really liked it a lot. So I think this is a decent topic to start out with. All right, then Thursday. We'll finish up with this topic, so we'll probably go over the intra-op, post-op stuff there. And then, actually, I don't have it on here, but when you look on in your modules, I also included pain in this. So I don't know if you have this printed out or not, or if you want to just write it down. Chapter 12 in your big book is all about pain. So if you want to include that in your reading for these, you know, Tuesday, Thursday here, you could do that as well. So I feel like, you know, every class we get into a little bit about pain. So it's not something that I want to spend a ton of time on because you've had it before, but we will talk about it a little bit, and it'll be part of, you know, stuff that you'll be tested on for the first test. So just, you know, keep that in mind. Okay, I put IB calculation practice here on Thursday because we'll do a little bit of practice math together as well after we go over our other stuff. Because, you know, every class you have that math test that you have to do, right? So I'm sure you guys remember that. So week 2, that's when we have our dosage calculation first test. So Tuesday, July 14th. So we'll probably do it first thing in class that morning. Remember, that's always 20 questions, and you can miss up to 2.
Excuse me.
Yes.
Is the dosage calculation test based on IV calculation, the drip rating?
So what it's going to be like, just
Yes.
give me a chance to explain it here a second.
Thank you.
So what it's going to be like is everything that you've done before should be on here, okay? So all of the simple type of dosage calculation things that you've already done in funds, that should be on here. And then we're just going to add like milliliters per hour, drops per minute type questions on here as well. So it'll be pretty simple. It shouldn't be that bad. Then throughout the term, you know, after this dosage calculation test is already done, throughout the term, we always have math on every test, and I will try to give you different concepts of different math things that we'll add, you know, as we go along through the term as well. Okay? All right, so week 2, other than the dosage calculation test, we are going to get into orthopedics. So we're going to talk about fractures and amputations and hip replacements and you name it. So that's all that stuff. Now, this arthritis stuff I put in here as well because really it's not necessarily orthopedics. It would be under a different category. But if you look at all of the topics that we go over through Adult 1, Adult 2, Adult 3, there's really nowhere else to put it. So I just put it here. So that'll add in there as well. Okay, so Thursday we'll finish up our topics. So it is all going to be orthopedics again. I just kind of put the same reading stuff for both days. Obviously we'll get through as much as we can Tuesday, and then we'll go through the rest on Thursday. So on Thursday, July 16th, you have your first assignment due. So this is ATI Fundamentals 2019 Practice A with remediation. So I will explain this more here in a minute. It'll make more sense when we're talking about the addendum. Okay, so I'll talk about it more there. But basically, this will be due that day. It's going to be due at the beginning of class. So that means after class starts, if you submit it like at 8:35 or something, it's late. You need to, everything has to be submitted before class starts. Okay, so just kind of get in the habit of doing that. Don't do it later in the day or during class or whatever. Just do it before class starts. So anyway, with this, I'm sure you guys remember doing all that fundamental stuff from funds. The reason that we do a little bit of fundamental stuff in Adult 1 is because you haven't had all of the content yet. So our classes are very short and fast, so you really don't get a chance to get all of the information that you really need to be successful on the fundamentals exam. So you will be doing a fundamentals proctored exam, towards the end of the term, and this time it's going to count for points. So by doing these practice tests here, A and B, it's just to give you a little bit of practice, okay? So even if you've already done it last term, you're going to do it again this time, okay? So Fundamentals 2019 Practice A with remediation. That'll be due on the 16th. Okay, week 3. We are going to go into fluid and electrolyte imbalances and acid-base imbalances. And I didn't really put it on here, but I'm also going to talk about like central lines and different IV type stuff as well during that time. So on Tuesday the 21st, you have 2 things that are due. So there is an ATI central venous access module that's due. And then there's also a case study that's due. So each one of those are worth 5 points. So I'll show you about every assignment here in a few minutes when we go over the addendum, so don't worry about that. But anyway, those will be due, so you have to turn it in before class starts to get credit for that. And then you see dosage calculation test 2 is there. So anyone who did not pass the first test, you will have a second opportunity to take it that day on the 21st. So what I will probably do is I'll probably do it at the end of class. So we'll probably just end at a certain time so that anyone else who needs to take the test can go ahead and just take it. We'll do it at the end. Let's see. And then Thursday, July 23rd, that's when our first exam is. So this exam is going to be over everything we did in week 1 and 2. And so I know you guys have your other class. What day is your other class with Mr. Tibbs?
Same day.
Same day? So it's later on today?
Yes.
Okay.
12:30.
So typically, it's always an issue. People hate having the test on the same day. So I try to make most of my stuff on Thursdays for you guys. And I believe he'll probably do Tuesdays. So hopefully it'll work out well so that you won't have it on the same day. Okay? So anyway, this first exam, usually the first one isn't too bad for people. It'll be all over that intra-op, pre-op, post-op stuff. It'll also be over orthopedics. So all of that stuff will be exam 1, and it's worth 150 points. Okay, so then week 4, we start getting into the GI tract a little bit. So we start out with the upper GI tract stuff. So this would include things like gastritis and peptic ulcer disease, and we talk a little bit about oral and esophageal cancer and things like that. So things in the upper GI tract. So I kind of split up the reading a little bit here for you so you can see when you're supposed to do stuff. So on Tuesday the 28th, you have another assignment due. So this is ATI Targeted Med-Surg 2019 Fluid and Electrolyte Acid-Base Imbalances with Remediation. So that'll be due before class that day. I put that here on purpose because I figure, okay, we just talked about all of this stuff, and now hopefully by that time you'll be, pretty good with it. So that's why it's due that day. Okay, so then Thursday, you have another one due. So ATI targeted GI practice assessment 2019 with remediation. So that'll be due on Thursday. So we'll keep going with our, upper GI tract stuff. And then when we go to week 5, we're going to start talking about lower GI tract stuff. So this will be things like Crohn's disease and ulcerative colitis and, inflammatory bowel syndrome, all those types of things. So on Thursday, July 30th, you're going to have another, or actually, did I just see a mistake here? Hold on. Or no. Okay. Yes, you're going to have that ATI targeted GI practice assessment that we talked about. That'll be due on that day, the 30th. Okay, so then week 5. We are going to get into that lower GI tract stuff that I just said, and then you'll have the ATI fundamentals practice B due. I tried to make that due a lot later in the term. So like in the beginning, we start with the fundamentals practice A and then make the B a little bit later. So again, you're going to have to do remediation with the templates with that. So that'll be due that day, also along with the case study 3. So both of those two things will be due. So we'll finish up with the lower GI stuff on Thursday the 6th, and then we'll have our exam 2. So exam 2 is typically the hard exam for everyone. So the reason is because of that fluid and electrolyte stuff. That's usually what everyone has the most hard time with. So chapter 13 is all that fluid and electrolyte stuff, and then what else will be on the exam will be some of the GI things. So I put chapter 43 through 46. So that means that it's pretty much all the upper GI stuff. So the lower GI stuff will be on test 3. Okay. All right. Also, I want to call your attention to the care plan for a second. Because there are so many of you in the class, I'm having 2 due dates for the care plan. So I put a list on Canvas under the modules that I'll show you here shortly, that I basically just split the class in half, and I have half of you due on week 5 and half of you due on week 6. The reason for that, it's just me. I'm the only one grading this stuff, and it takes forever to get through these care plans. They're really in-depth and long, so I can't be responsible for grading 3 million of them in 1 week, before the term is done. So I tried to do it this way on purpose. So anyway, week 5, it'll be Thursday, August 6th, that group will be due. This is the only assignment that we have the whole term that will be due by midnight. So when you do this care plan, obviously you're just going to turn it in on Canvas, and you'll upload the file onto the Canvas thing there, and you can do it all the way up until 11:59 that night. Okay. So the other group will be due on August 13th. So see, I have it there both times.
I have a question. How do we know, like, where did you say to go to find out which group we in?
I'll show you here in a minute.
Okay.
It's on Canvas.
Okay,
I'll show you. Okay, so just so you are aware, there's 2 different groups, so you have to be aware which group you're in so you know when it's due. I only have 1 Dropbox on Canvas, and it has a certain date to it, so don't let the date freak you out. So like I believe the date is for this week 5. So like if you turn it in week 6 and it says that you're late, you're not. You know you were supposed to turn it in on week 6. That's okay. I didn't want to make 2 drop boxes to confuse people. I just thought we'll just do the one, and it makes you put in a date. So I just put in, the week 5 date. So don't get confused about that. All right, week 6, we get into stuff about the hepatic and biliary system. So we talk a lot about cirrhosis and hepatitis, and with the biliary system, it would be things like pancreatitis, cholecystitis, that kind of stuff. So that's what we'll be doing that week. So Tuesday, the 11th, you'll have a case study due. And then on Thursday, this is the day we're going to do that proctored exam. So this proctored exam is going to be first thing. So when we get into class 8:30, that's when we're going to take it. So you guys have taken it, taken the other one before. This is going to be the same thing, but slightly different. So they have a different version of it that you're going to take. So again, it'll be first thing, and then when everyone's done, we will come back on here so I can continue to go through content with you, because otherwise you're never going to get everything. So we'll go over the rest of the content that we need that day. All right, and then the stuff that we end with in Unit 7 would be hematologic disorders. Now, I've only done this a couple of terms now. I've been teaching med-surg for a while, but I felt like at the end of the term we just didn't have enough of everything to do, so I put in this hematological disorders because you don't get that anywhere else in Adult 2 or Adult 3, and it's kind of an important topic to go over, so I just put it there. So this was chapter 32 and 33 in your big book. And basically we talk about things like anemia and folic acid deficiencies and, thrombocytopenia, stuff like that. So it's kind of interesting. So that stuff will end up being on your final exam. So anything from Unit 7 on will be final exam. So all of this new stuff that you talk about week 7 will be on there, and then everything else will be cumulative. So on Thursday the 18th, you have this blood administration module that you have due. And then notice right here on Thursday the 20th. So see where it says ATI Fundamentals Proctored Remediation. Geez, I have a typo there, I know. So your remediation for that proctored test will be due that day. So after you take the proctored test, you print out your printout, and it'll show you if you're level 1, level 2, level 3, and you have to do remediation for this. So just like for all of the other things we're talking about, it'll be the same way, and you will turn it in by this day, by the 20th. So if you do it early and turn it in, that's fine. I'm fine with taking stuff early, but that's the day that it's due, the 20th. In order to get your points for that proctored exam, you have to do the remediation. So if you just take the proctored exam and say you got a level 3, which would be 80 points, you don't get those 80 points unless I get your remediation. You would get a 0. So you have to do the remediation. All right, and then our exam 3 is that day, the 20th. So again, this will be the lower GI content, so all of that stuff, and then also adding in this hepatic and biliary stuff.
I have a question.
Yes.
For the remediation, is that something that we're coming online to talk to you with, or is that just retaking the test again?
No, I'll show you exactly what you need to do. Don't worry.
All right.
All right, so anyway, that's kind of the syllabus here. So I have the breakdown of all the points here. Okay, let me see if I can show you a couple other things. Okay, so here's our canvas, all right? So I'm gonna get into modules. Can you guys all see that okay, modules? Okay, all right, so I'm gonna show you a lot of stuff. I put a ton of stuff on here this term, which I didn't do this last time, but I had time this time, so I did it. Okay, so at the top of the page, it says read me first. There's a ton of stuff up here at the top that is kind of important. So I know a lot of people just skip over that and don't even look at it. But anyway, so there is a library thing right here. So like instead of getting out of this Canvas tool and going into that other thing to get into the library, you could just get into it right here. Did you guys know that? So you can go into library and get into it there. Also, another thing about the library that is really important, when you are going to do your care plan, and I don't know if you guys have looked ahead at stuff, but you have to do APA 7th edition for your care plan this time. And so if you're really unsure about that, we have a nice little library lady right here, and you can email her, and she is very helpful with that stuff. So use her, you know, that's her job. So she's really helpful with any kind of APA anything. I actually have done that for my doctorate stuff. Sometimes I'm not sure how to cite something, and I'll email her, and she's really great about it. Like you can actually just chat with her and everything. So it's really easy. Okay, let me get out of that. All right, so other stuff I want you to pay attention to, which I don't know if some of you who had Clinical Monday, if your people showed you this or not, but I'm just going to show you anyway. So virtual clinical and lab information. So go in here and look what's in here. So all of that stuff that you have to do for clinical, you know, like you guys for Monday, we're supposed to do Edith Jacobson, that VSIM. So here's all your worksheets that you need to do, like the concept map, the Farm for Fun, all of that stuff is right here. So that's how you get into it, and you could print it out from there. Also, for VSIM, there's pretty much 4 VSIMs that you have to do. So they're listed right here. Edith Jacobson, Kim Johnson, Marvin Hayes, Sarah Lynn. And then if you ever have trouble with VSIM or DocuCare with anything, you can contact them right here. So this tells you their hours. Here's like a website. They have a phone number listed on here as well. There's all kinds of stuff here. So make sure you go into this. This is super helpful.
I have a question about clinical.
Okay, go ahead, but I was going to tell you some more. I probably will answer what you're going to ask me. But go ahead.
It's about the med cards.
Okay.
Do we use the ATI medication sheet for our med cards, or is the Farm for Fun considered the med card?
What did your clinical instructor tell you to do?
I have clinical tomorrow.
Oh, okay. Just go with whatever she says, because every clinical instructor is probably going to be slightly different with that. Okay. I told each clinical instructor to make you guys at least do 3 meds every week. So it's up to them which ones you do. I gave them a huge list of meds, and they just have to pick from there. So everyone's going to be slightly different. So just do whatever they tell you to do. Okay. So let me show you something else. I'm going to get off of this page just a second. So this morning, I talked to Jen Ryder, the student support person at our campus, and she gave me this. So I put it on here for you guys under announcements, which I don't know if any of you have looked at this yet, because I just did it before class. So I know yesterday was the big cluster with clinical, because the people in Wisconsin were supposed to make everything so that we could all get into it, and nothing was available for anyone yesterday. So all of the clinical instructors, a ton of the students, no one could get into things yesterday. It was a big cluster. So it was their issue, because they needed to make it accessible for us, and they didn't do it until like really late in the day. So it was ridiculous. So hopefully it should be good for everyone else for the rest of the week. However, so don't forget that you guys need to go into the bookstore and get your access codes. So the access code is that 12-digit number that you need to put into the point, and that is going to be able to help you get everything that you need to get, okay? So this is steps on how to do that. So you basically just go into the bookstore like you would validate your books, and that's how you get it. So make sure you go onto here and look at this. So you need that 12-digit access code that you put in first, and then the two codes that I gave you, the DocuCare and the vSim, should work for you. Those are class codes. So you do the access code first, and then you put in the class codes, and then you should be good. Again, if you're having issues after you do all of that, then you have those numbers of people for vSim that you can talk to. Okay? All right, so anyway, after that virtual clinical and lab information, there's the shadow health information. So for clinical, you have two different things that you're doing this term, so vSim and shadow health. Shadow health is slightly different than vSim. I don't know, I kind of like it a little bit better. You guys see what you think when you get into it, but so they just don't have as many vSim type things to do. That's why we are doing both. And so like they didn't want to keep going with just a ton of vSims every term because we don't, first of all, there isn't enough. So like even though you're in med surg, you're doing some more fundamentals vSims this term. I don't know if you guys realize that, but those 4 that you're doing are fundamentals. It's the only reason is because they don't have enough of the med surg ones to give us. We have 3 med surg classes, and so there's no way, So anyway, with this shadow health, this is all the information about that. And see, look at all of these things that we're going to be doing this term in clinical. So there's 3 million of these things here. The thing with these is, I think these are a little bit shorter than the vSims. So if you think the vSim takes too long, this is a little bit better, I think. It's a little bit shorter. So with this, there's like an orientation thing you're supposed to do, and then all of this stuff is like pharmacology stuff. So they have a bunch of math things on here, and then they also have a couple of like here's an intermediate patient case, complex patient case. There's different things you do on here as well. Then they also have these concept labs. These are more like educational type things that you do, and you just go through and do what it says, and it's just stuff that you read, and it's nothing that you really do per se. You'll see when you get in there, it's not that bad. So anyway, even though it seems like there's a lot of stuff, it's not going to take you as much time as you think. It's pretty quick. So anyway, for this, technical support information is here at the bottom for shadow health. So if you have any issues with that, they talk about how to reopen an assignment and how to mark an assignment as turned in. So all of that's right here. So that's that one. All right, and then at the bottom, we're still in this read me first up the top here, okay? So there's a thing that says vSim and DocuCare, and there's a thing that says shadow health. And this was our problem yesterday. They didn't have the shadow health thing here at all. They just finally put that in last night. So anyway, both of these are just your way of getting into there. So you don't have to keep clicking in 3 million places to get into your stuff. So like if I click on this, it'll take me right into vSim, to get in here. And then same thing with shadow health. This is your link to get into shadow health. So this is mine, so it's going to look slightly different than yours, but so ours is going to look like this. So it should say Adult Nursing Systems 1, Pharmacology Cases, July 2020. That's our class. So you would click on that. When you get in there, it'll kind of look like this. So up at the top, there's something that says Introduction Video, so I would definitely watch that when you first get in here and do these. And then if you still feel like you don't know enough about shadow health and you want to get more information, up at the top, and I don't know, I'm pretty sure it's the same way for students, but like I know for me, for here, it says My Resources, and there's like a training course you can do right here. Okay, so that's just know that that's there in case you need it. Now, with all of these things that you're supposed to do, if you just page down, here's all your cases right here. And you just click on it and it tells you what to do from there. Okay? So that's that stuff. All right, let me stop sharing just a second so I can fix that. Okay. All right, so we've gone through all this stuff under README first. So then let's look down through here. So I tried to put, gosh, this is still out of order, stupid. I'm gonna have to fix that again. Here's your case studies. So the case studies, they're pretty much due weeks 3 through 6, I believe is what it was. So like the first one, week 3 would be this one right here, first case study, Chad, number 22. So when you click on that, here's your case study right here. So I had to scan these, so hopefully you can see everything okay. But so basically, like all of the stuff at the top you ignore because we're doing Chad. This is someone else right here. So we start right here at Chad. So you read through what this says, and then I don't know if you can see this very good, but see where it says e-resource? It says, hey, to learn more about CT scanning, go to Medscape, and it tells you exactly where to go. So follow these things and do what it says to do as far as where to go for these things, because it helps you answer the questions right. So it sends you to different like websites and stuff. And so basically you're just going to go through here and answer these questions and do everything that it says under these e-resource things, because it'll help you answer things correctly. So then you would fill that out, and then you're going to turn it back in to me on Canvas to get your credit for that.
How are we supposed to fill those out if it's scanned?
Do you have the ability to print?
Not at my house.
If you don't have the ability to print, you could, I'm sure you have like a Word document or something that you could just answer stuff on a Word document and send that to me on Canvas.
Actually, I don't have a Word on this. I had a loaner computer and they told me I had to pay for Word, but they told me I can get free Word. I don't know how to download it.
Okay, well, we'll have to figure out something so that you could do that, because that's part of your assignments. You're going to have to be able to do that.
If you
So
call if you call IT, they should be able to walk you through how to download it, because you should be able to get it for free because you go to Hurricane.
yeah.
So once you get Word, when I open this, I'll be able to write on it?
Yeah, so Word is just like...
No, I know what Word is. I'm just asking. Once I open that, would I be able to write on this?
So what you're going to do then, you're going to have to look at this in one, what am I trying to say?
Document?
Like one
screen.
Yeah.
So you're going to have that on one screen and then have Word open on another screen, and then just look at this paper and then just type your answers on the Word screen, and then put the Word document in the Dropbox.
I mean, I seen some question with like a graph. That's why when you go down,
this is the only one that has that.
Okay, so that's why I was asking, because it's kind of confusing. So I'm just trying to I'm not really good with computers, so I'm just trying to make sure when I get on it, I'm not extra frustrated because I don't know what I'm doing.
No, that's fine. This is the only one of the case studies that has that. So with this, if you don't have the ability to print, you can't do that part. I'm not going to you know, that's okay.
Okay.
Well, would we be able to like say the quadrant?
Yeah,
Or
you could probably do that.
Instead of like trying to write it on there, we can just type in like the quadrant that it would be in, like
Yeah.
you know, right, upper, lower, left, lower, like that.
Yeah, you could do that. So yeah, these case studies, I mean, don't let them get you frustrated. I know last term when I used these with people, some people were getting irritated because of some of these websites are a little different, but if you're having trouble, just let me know and I'll try and help you get through it. So just, you know, let me know.
All right, thank you.
All right, let's see. So that's the case study. So that's where you find them. So that we're under modules, and there's a thing that says case studies here. Every time I get on here, I swear this stuff is in a crazy order. I had it all correct yesterday. I don't know what happened here. Let me go find the other stuff. Okay, here's the care plan. So obviously we don't have actual patients, you know, because we're not at clinical. So we have to do a stupid scenario care plan, unfortunately. So here is what I did for that. So I put your directions here at the top. So I just said you're going to use this following information in the scenario to do your care plan. Last term I had people making up information in addition to what I put here, and I'm like, I never asked for that, so I don't need you to make up anything. You just use what this gives you, and that's it. So read through the scenario and try to figure out what the problems the patient has are. And then you go to your nursing diagnosis book and you say, okay, you know, maybe one of my problems in this scenario, this person had pain or something. So you say, okay, what can I use for that? And hey, you know, you have acute pain or chronic pain. So you would have to read in your nursing diagnosis book the criteria for that. And you'd say, okay, the criteria says this, I think that fits, so this is what I'm going to use for my diagnosis, right? So on the care plan then, you are going to do 3 priority diagnoses at the top. Actually, let me just show you that because it'll be easier, I think. Okay, so here's the care plan, right? So here's the first page where you would put, you know, obviously this person, I think it's only like a 1-name thing on this scenario, so you would only be able to put their name there. For date of care, you can just put whatever day you do your care plan on there. If it tells you an age and a gender, you fill in all of that stuff as much as you can. If it gives you lab values, you're going to write the lab values, and then it's a significant of abnormals. So that means that if something is abnormal for a lab, you need to tell me why you think that's abnormal with this person. So in this box then, at the bottom, you're going to put a citation for your lab manual. Everyone in here should have a lab manual in their ebooks. So you need an APA in-text citation here for your lab manual. Where it says treatments and orders, this is just like, say they order a special diet for someone, or they order a special bed, or if they have a dressing change that they have to do, anything like that, that would be what you would put there. In the middle here for physical assessment, they have subjective and objective things. Obviously for this, you're going to get rid of this red, right? Yes.
On my screen, it's still
I only see the care plan. Yeah, I don't see anything else.
All right, hold on.
It doesn't even have.
I was wondering, I was like, what is she talking about?
Hold on, let me
Okay.
fix it. Can you, here. Let me just do this. Can you see this now?
No.
Yes, it's just like the scroll down or something. Yeah.
You can see it though?
Yeah, we can see that. That was just
Okay.
the top that was
All right.
showing before.
That's fine.
Okay.
All right. So again, on this first page, here's where it says physical assessment, subjective, objective. So you're going to put things from that scenario in here. So anything that that patient said that was subjective, you're going to put here. See where this red writing is? You're going to delete that. That's just tells you what to put there. That's not something that you would keep there. So delete that. And then your objective information, you know, things like vital signs and stuff like that, you know, maybe you'd stick their weight or something.
I'm sorry,
so-
I had missed where you said to go to find the care plan. My background was loud.
It's
Where did you say find the care plan?
everything's under modules.
Modules, okay.
Okay, so then on the left-hand side here, you see where it says past medical and surgical history. So if you get something about that in the scenario, you're going to put that there. History of present illness. What does that mean, everyone?
So that's like
his
how
illness, what he does.
long they've been dealing with that illness.
So what
Is there
this,
a reason why they're there?
yes.
Yeah.
So
what he
like,
does.
say for instance, if we had a scenario that said, you know, someone was at the gym and they started to have chest pain when they were on the treadmill, you know, and they give you like the whole scenario about that, that's what you would put here for history of present illness. Oh, I was at the gym, I was walking on the treadmill, I started to have sharp pain in my chest. It was a 9 out of 10, I started sweating, I got off the treadmill, told someone to call 911, and now I'm here. You know, something like that. So that's history of present illness. Then down at the bottom, IV site, fluids, rates. This is where you're going to put your IV site. So I want like, hey, it's in my right hand. It's a number 22. It's hooked up to normal saline at 100 an hour or something. I want that right there. You really don't need to stick anything else there. That's all I want. All right, here's where you put your 3 priority diagnoses, okay? So this does not mean that you say just the diagnosis only. You have to put all 3 parts to your diagnosis here. So for each of those 3 diagnoses. So for instance, if I had a diagnosis that was impaired mobility related to broken leg as evidenced by needing assistance of 2 people to get up and down, you know, something like that. That would be in here in my 3 priority diagnosis. I would not just write impaired mobility. Do you see what I'm saying? If you guys just list the diagnosis only, I'm going to mark it wrong. So you need to have all 3 parts for all 3 diagnoses at the top. Does everyone understand what I'm saying?
Okay, so what do you mean by your all 3 parts?
Like related to Evan's,
Oh, okay.
yeah.
Like all the, okay, like work them out basically.
Yes.
Work out the
Yes.
diagnosis, okay.
Yes. Anytime you see a nursing diagnosis, you should be putting the whole thing there. You should not just be writing
Yes, I
just
understand that. My other teachers just worded it different. That's why I had to confirm what you were talking about.
Okay, that's fine. Okay, so everyone listen to me. So after you put the 3 diagnoses here, you're going to choose one of those 3 diagnoses to care plan out. Okay, it doesn't have to necessarily be the number 1. It can be the number 2 or number 3. It doesn't matter. So you pick one of them, and then you're going to use that to diagnose out completely. So for example, if it was my impaired mobility, I would put that here. Impaired mobility related to whatever as evidenced by whatever. So I'm going to put that in this column, and then I'm going to list 1 goal, 1. And it needs to be short term, not long term. That goes in this column under outcomes. Then under nursing interventions, I need to have at least 4 nursing interventions, at least 4. You could do more if you want, but you know, at least 4. And then for rationales, I need 1 rationale for each intervention. And your rationale needs to have an in-text citation with it.
Are we required to use the nursing diagnosis book given to us by Herzing, or can we use other resources?
Well, let me be clear about what I want you to do here. People do care plans wrong all the time. So, excuse me, what people normally do wrong, what students do wrong all the time with this, is when they look for their rationales, they look for them in their nursing diagnosis book, and that is wrong. What I want you guys to do is I want you to use your textbooks. So your Med-Surg book or your fundamentals book or whatever, I want you to use those books. Or you could even use a journal article, like if you go to the Herzing Library and get a journal article about what you're trying to find. That's what I want you to use, not your nursing diagnosis book there. It doesn't mean you can't use your nursing diagnosis book to help you pick out like an appropriate diagnosis. That's what the nursing diagnosis book is for, you know? So your care plan book is not one that you should be getting rationales from. And the reason I'm telling you that is because they don't give you good enough rationales. They might be somewhat okay, but they don't answer everything that you need to be answering under the rationale. So a good rationale needs to answer why an intervention works or how it works. Most people get marked wrong in rationales because they don't go into enough depth of answering that at all. They don't put enough there. So you know how I said you need an in-text citation there? So do you guys all understand how to paraphrase something?
Yes.
So if you can paraphrase something from somewhere, you can make anything work for your in-text citation. That would be the better thing to do.
How?
So, say that again?
I said how?
So with
in-text citation to make this paraphrase to get through with the in-text citation.
With paraphrasing. So like say I look in my book and I don't know, maybe I have an intervention for incentive spirometer, okay? So when I look in my book, I need to find something that says why using that incentive spirometer is going to help this person if, like, I don't know, maybe my person has problems breathing or something, I don't know. So why is using the incentive spirometer going to help in this situation? That's what I need to find. So when you look in your book, you can say, hey, using the incentive spirometer would be helpful to a person with atelectasis by, and then you can put what you find in the book. You see what I'm saying? Like you need to kind of like put your own little wording there at first and then put like what you see in the book. You see what I'm saying? Most people this is another thing I saw a lot last term. So with rationales, people would be like, this helps because it does this. What the heck is this? How am I supposed to know what you're talking about? You need to like mention your intervention in your rationale. Do you understand what I'm saying?
Yes.
Yes. Yes.
And honestly, if you don't, it's okay. I mean, we'll work together with this and try and figure it out. It'll be all right. So that's the rationale. So if I have 4 interventions, I need 4 rationales. It has to be a specific rationale for each intervention. And then evaluation. For evaluation, it's not okay to just say, yes, the goal was met, and that's it. You have to say more than that. Make sure you look at the rubric for the care plan. The rubric tells you exactly what we're looking for. So basically what you're supposed to say is yes or no that the goal was met or not, because we're evaluating just the goal, the one goal. Do not evaluate your interventions. That's not what I'm asking for here. So you put yes, my goal was met, or no, it wasn't. And then I want you to tell me why you think it was met or it wasn't met. Tell me why. If it wasn't met, you need to write a revision. And a revision means that you are writing a new goal. And that would go under that evaluation column. So you would say, no, my goal was not met because of whatever. And then you would say, here is my revision. Here is my new goal for next time. And you would write that there. Okay. All right. Other things in the care plan. So there is a whole medication list here. So you don't have a ton of medications. I want to say maybe there's 5 or 6 in that scenario. So you're going to list the medication name, the dosage, the route, and look at this column right here. It says action and classification. So people get points marked off all the time because they just do one of those two. It's asking for both. That means you need to say how the medication works, you know, what's the action of that medication, and then put the classification of that medication here as well. And make sure you're being specific about classifications. I don't want to see antihypertensive. I want to see what type of antihypertensive it is. So be specific. And then it'll say, hey, why is this person taking this? What's the side effects? What's the nursing considerations? Again, because these are medications, I should see an in-text citation for your medications for, you know, from a med book. Then the last part of this just has to do with the assessment. So unfortunately, you guys aren't able to assess someone and like put it in here yourself. So you're just going to put what it says in the scenario in here. So again, here's a section for subjective and objective data. And then you're going to go through each one of these boxes where it talks about these different areas, and you're going to put in things from the scenario in each one of these areas. Obviously, I may not have given you enough information to answer everything in each one of these areas. That's okay. You only have what you have. You put only what you have from the scenario in here. And then at the very end, you're going to put a reference page, right? So someone was asking me an email about 7th edition APA. I get that you guys may not have a 7th edition APA book. I get it. But you can easily look up that stuff online to find things for that. So this is your template here for the care plan, and just know that this template is old. So like this running head, that goes away with 7th edition APA, so this would be gone. So you would have to delete that. And like some of the stuff on your title page, like I have an old student's name here, like some of this would be different. So you need to look at that and make sure you're doing it the correct way that it says to for 7th edition. Okay? All right, so that's the care plan stuff. So I have to keep getting in and out of the screen here. Okay, so again, all of this is under modules, so everything I'm going over is under that. Okay, and after class, I'll make sure this is all in the right order so these don't jump anymore. So see where this says care plan due dates. So this is where you decide if you're a week 5 or week 6 person. Okay, so you just open that up and it'll tell you which person you are. I basically just split people in half. Okay. So that's where that is. All right, the other things I want to show you is this. Okay, so as far as discussion goes, I know some of you already have posted like an introduction of yourself, which is great, and I appreciate that because I don't know the majority of you guys, so that's kind of nice for me to get to know you a little bit that way. But as far as discussion goes, we don't get points for discussion in this class. So most people are like, okay, well, if I don't get points, I'm not going to do it. However, I put in here, every week I have a discussion, and I just put in basically a case study about what we're talking about. And so like by Thursday of that week, you answer the one part of it, and then by Sunday, you answer the other part, and that's all it is. So essentially, it might be helpful to you to do it. So if you decide you want to, that's fine. If you don't, you're not going to get penalized for it. But this is the other thing. If you end up missing class one of the days of the week, if I see that you've been in the discussion board, I could still give you attendance. But if you haven't been in anything at all, then I can't give you any attendance for that day. You see what I mean? So like if you miss class, this is your way of getting attendance, you know, that way. So just kind of consider it. It's might be helpful to some of you to do that. All right, for our assignments on our syllabus, we were talking about all those ATI assessments that you do with remediation. Let me show you an example. All right, so this is someone that I had from a previous class, so I blacked out their name. But so basically, when you do any of those assessments, you're going to print out your printout that's going to look just like this, individual performance profile. So it'll have your name, it'll have your percentage that you got right, how much time you spent on it, all that kind of stuff. Then, you know, once you look over here, it'll tell you like how you did in each of these columns, which I don't know why this isn't coming through right, because she should have more of those things there. But then underneath that, it says topics to review. This is how you're going to do your remediation. So when you like take one of these tests, you're going to look at the percentage that you got, and then you're going to look at your addendum, which I'll pull that up in a minute to show you. But on your addendum, there's a spot on there that tells you, okay, if you got this percentage to this percentage, this is how many active learning templates you're supposed to do. Okay, so that's how you have to do that. So you look at your addendum and it'll tell you how many to do. So like this person had 60%. So if I'm remembering right, I think for you guys, it's like 6 or 7 templates that you're supposed to do, something like that. So then you look under this topics to review, and you're going to find a bunch of different things that you got wrong on that test, and you're going to pick which ones you want to do for your remediation. So maybe I want to do this airway management, tracheostomy suctioning, and see how it says active learning template nursing skill? It tells you which one to do. So you would, you know, use the nursing skill active learning template and fill that out. So I've had people last term like just type on their active learning templates, and then I have some people who write them out and then just send them to me. Honestly, writing them out is probably better because then the information might stick with you better. But if you have to type them out, that's fine. I'm not going to throw a fit about that. So anyway, so there's going to be a ton of different topics to review on these things. So you just kind of look through and figure out which ones you need. Now, don't do these the wrong way. So some people will be like, oh, I'm going to do management of care. And they'll write management of care on their template and then like write everything about management of care. When that's not what you got wrong. It was this: delegation and supervision, delegating tasks to the system personnel. Say it's that topic that you should be writing down.
So you would choose one topic from each item, like that would be management of care. You would pick a topic, and then health promotion, maintenance, and you would pick a topic. Is that what you're talking about, like onto the template?
Yeah, like you don't have to, here, sorry. Okay, like you don't have to just pick one from each section. Like you could do every one of these if you wanted to under management of care.
Okay.
But I'm just saying, watch what you're doing your topic on. It's really like this little writing here is what you actually missed. These are just bigger areas. You see what I'm saying?
Okay.
So if you did it on assignment, delegation, and supervision, it kind of is answering this, but kind of not. You have to really look at this particular thing right here.
Okay.
Okay?
All right. Thank you.
So when you're turning these in, you're turning in this printout. So you have to give me the printout, and you have to give me the correct amount of templates with it. That's how you get your points. So going back to, let me go back to the module here. So in here, I put links to all of these templates here. If this doesn't work for some reason for you, because sometimes I get someone that says, oh, my link doesn't work. Well, this is also on your ATI, and you can get them from ATI. So like, here's an example of what the basic concept one looks like. So it basically just looks like this. And it has 3 big long sections, and you put information in each thing. There's one on diagnostic procedures. There's one on medications, nursing skills. This one here is on like, if I can open it here. This is growth and development. So see, they have physical development, cognitive, psychosocial, age-appropriate activities. What can you do to promote their health? Immunizations, health screening, nutrition, all that stuff's on here. So on your printout, then it'll tell you exactly which template to do. And then you have to kind of look at what you did wrong to see where you have to go to get that. So like for the fundamentals practice A and B, everything is going to be in that fundamentals book. For any of our other assessments that aren't fundamentals, things like the GI practice targeted assessment, that stuff is probably going to be in your Med-Surg ATI book. So you would look in there for those things. Is that making sense to people or no?
Yeah.
Kinda.
Well, make sure if you don't understand something, you ask me before you turn it in so you don't get something wrong.
Right, I will.
Are we just picking us? You want us to do all the ones we missed or just a certain amount?
No, there's just a certain amount. So again, you're going to look at your addendum to figure out how many of your active learning templates you have to do. Your addendum will tell you. There's like a chart on there.
Can you open the thing for the addendum? You said you was going to open that. Okay. And I think once I see that, maybe it will all kind of click.
Yeah. Here, hold on. Can you see that, or do I need to stop sharing and reshare?
I see it.
You see it? Okay. All right, let me flip to the spot we're talking about.
On my screen, it doesn't show that you opened the addendum. It just has the announcement where it says, here's
All right.
the electronic.
Here, let me just reshare then so you can see it. You see it now?
Thank you. Yes, ma'am.
Okay. All right, this is inside your addendum. There's this whole chart here that this is what you're going to look at. So see where it says remediation table. So on that one, that example one I just showed you, that girl got 60%. So see where it says 60% to 79.99, you do 6 active learning templates. That's how you figure that out. If you do like really good on your assessment for some reason, like say you got a 98% or something, regardless, if you get 80% or above, even if you got 100% on your test, you still need to do 5 active learning templates. So that means if you don't have any topics to review on your printout, you get to pick which ones you want to review and pick your templates to fill out. So no one's perfect. So no one knows any medication and every skill and everything. So you can pick out of your med-surg book, out of whatever we're talking about. So like say it's the GI practice assessment. Well, anything having to do with GI, you can pick your topic then to fill out. So maybe you feel like, oh, I don't know lactulose very well. I'm going to fill out a medication template about lactulose. So you could do that. Or maybe you don't understand how to do a liver biopsy. So you could pick, the therapeutic procedure one and do something about liver biopsy. You see what I mean? So anything that is about that topic, then you would pick that. If it was the fluid and electrolyte one that we were doing, you would have to pick something having to do with that. So if it's about potassium or calcium or anything having to do with those things, you could pick that out. Do you see what I mean?
So by us doing this, is this giving us our points back? Like if we scored low, like is this giving a point?
No.
Okay.
You don't get points, for what your percentage is on there. That's not how it is. If you look on your syllabus that I went over with you, you only get a certain amount of points for doing these.
Right.
So you get that same amount regardless. The whole purpose.
Thank you.
The whole purpose of remediation is just to help you get that information in your head better that you missed before.
Okay, thank you. I understand what you're saying. Thank you.
Sure. Now, when we do that proctored test, the proctored test, same thing, whether you get a level 1, level 2, level 3. Now, again, we're on the addendum. Let's look down here a second. So this is the thing for the proctored test. So if you get a level 3, you could get up to 80 points. If you get a level 2, you could get up to 60 points. If you get a level 1, it's 56. If you get a below level 1, it's 30. So this can totally screw you up in this class if you don't do well on this proctored test. So when you print out your printout after that test, obviously it'll tell you what level you are, but the thing is, you need to look at that percentage. It'll also tell you the percentage. So again, you're going to look at this right here to tell you how many templates you have to do to turn in with it. So if I got like a 76, then I need to turn in 6 templates to go with that. Make sense or no?
Yeah.
So the way the points work with the proctor test is, again, it's all about those levels. So if I got a below level 1, even though I turn in my remediation, I still get 30 points. That's it. Because I scored a below level 1. So you have to work really hard to do well in those proctor tests.
When is the proctor test again? I think I missed that.
It's later in the term. I want to say, let me look at it real quick. It's week 6.
Okay, now, and the proctor test is just over like the whole class, or like is it over like a specific topic?
It's fundamentals. It's just like what you did last time. It's fundamentals.
Oh, okay. Okay.
Okay. All right. I guess I'll just keep going over this real quick. All right. So with this addendum, again, we have all of this stupid stuff in the beginning that no one cares about. So we always have this chart that talks about program outcomes and course objectives. That's always in here, so you can see what that says. There is an evaluation tool that we would normally use if you were at physical clinical. I left it there because you need to see what you would be evaluated on, so you know what you need to be acting like when you're at clinical. And then I also put in here this. This is what I sent to every clinical instructor this term. This is how they're going to be keeping track of each one of you and what you do. So like your name would be at the top, and there's one individual one for every student. So they would write what case you did that day. So like if it was Edith Jacobson, they'd write that there. They'd write check marks for all the things that you turned in. And then they're going to say if you were satisfactory or unsatisfactory for that day. And then they could also put a comment in here. So like say you didn't do something right and they had made you redo it, they could write that there in the comments. And then at the end, they're going to say what date the clinical was and how many hours you had that day of clinical. That's how we're keeping track of stuff. And this is the all of the assignments that you're supposed to do each week for clinical, which they all have. So again, like the people on Monday, they had to change up what they were doing. Normally they would have done shadow health, but they didn't have access yesterday. So they moved on to week 2 and they did this stuff. So next week, you guys are going to do week 1 stuff because you had to skip that. And then everyone should be on the same schedule. So notice week 4, I made as a short week. So see, you only have 4 hours, 35 minutes of clinical time here. And it ends up working out okay with our hours anyway. But I did that on purpose because I figured if people have to turn in care plans and stuff, they need some time to be working on that stuff. So that's why I did that kind of in the middle of the term. And then you'll be done with clinical after week 6. So I put here expectations of clinical. You must complete all your scheduled paperwork for the day and turn it in on Canvas in the assigned Dropbox. You have to complete the scheduled amount of time for your clinical day. This includes attending both pre-conference and post-conference and making sure that you are active in that and talking to people. If your instructor informs you that you have to redo something, make sure you do it in a timely manner. And then you know, you get only what you put in, you know, to clinical. So if you're not going to get anything out of it, that's not because you're not participating good enough. You need to get what you put into it. So every clinical instructor will tell you their expectations as far as like when you have to turn things in. I don't know what you guys had last term. I know some people were like saying you had to turn in everything that day, which is crazy, I think. So, but the thing is, the reason people do that is because we have students who are like, oh, I'm going to work on my clinical day. No one's going to know because, you know, you should not be working on your clinical day. You need to get in your hours for clinical. There's a whole reason that we have this whole breakdown of hours. You know, the Board of Nursing is very particular about that. So you need to be doing the right thing here. So do not work on your clinical day. Make sure that you're spending your time doing your clinical stuff on clinical day. All right, we don't have lab with this class, so there's nothing there. I put the Herzing Price of Success stuff here that you guys can read through. As far as like missing class, I would hope that you guys could come to every class. But obviously there's stuff that happens sometimes where you can't come. So if you can't be here for some reason, make sure that you notify me beforehand. And if you have a good excuse, and this lists what good excuses are, then you can make up stuff that you miss, you know? So if you have an excused absence, that means that you have usually a week to turn that stuff in. And you have to give me your excused absence. You know, I have to receive it through email. You know, so like say you had a court appearance, I would need something official from the court saying you were at court. So you would have to email that to me. With you know, sickness, if you're sick for some reason, So the only thing, like when we're at school, when we're physically at school, there's all kinds of people who will be like, oh, my kid was sick, I couldn't come. And I get that because I have kids too, and I understand you have responsibilities to your kids, you have to do that. But that's not an excused absence. It's only excused if you are the sick one. And so you would have to have some kind of doctor's excuse that you would give to me proving that you were sick. So that's kind of how that stuff works. But just make sure you treat class just like it was your job. You know, if you have to miss for some reason, you tell me. You would do that to your job. You call ahead of time and say, hey, I can't be there. Same thing here. Treat it just like it's your job. Let's see what else. Okay, here's the stuff about the assignments. So with fundamentals, practice assessments A and B, again, you print out that module report, you know, the whole report like we were just looking at, and you do those active learning templates just like I showed you how to do. There's no partial points awarded for this, so you either get your whole 10 points or you get a 0. So you have to make sure you do it correctly. If you turn in something and it's not quite right, like the remediation isn't done quite right, I can go back to you and say, hey, I'm glad you turned it in, great, you'll still get points, but I need you to redo this before I put your points in. So I can tell you that. But again, I don't accept anything late unless you have a good excuse for some reason. So make sure you turn stuff in early if you can. So there are some modules that we have to do. That's part of our assignments this term. You guys, have you done modules before on ATI?
Yes.
I'm assuming you guys all have, right?
Yes.
Here, I'll pull this up. All right, this is my ATI. It's going to look different than what yours does. It's just because it's a faculty one. So when you do any of those modules, like I know there's a blood module where you have to learn how to give units of blood and stuff. You would go into your ATI and you would go under skills modules. So when you open that up, there's 3 million different modules in here. And so you just look for the one, like this would be the blood one, the blood administration. So you go in, if it ever connects. Anyway, you go in and usually they have like a pre-test or something that you're supposed to do and a post-test. So say here's the pre-test, you could go in and start that. And then once you do that, you can go in and you spend time in the lesson. So there's all these different things in here that you could look at, but basically I would read through all of this accepted practice stuff. I would go to the step-by-step viewing and watch the videos, and then just look at some of the other stuff here at the end. For modules, you have to spend at least an hour in the module. And the report that you print out has to be the module report. Can't be anything other than that. So the report that you print out is going to have like the time that you spent. It'll show how you did on the pre-test and the post-test and all that kind of stuff. So,
Ms. Cook, I looked for that last night in my ATI, and I could not find anywhere, like there was a section for download and report for the pre-test. There is a tab for download and report for the post-test, but I could not find a download and report for like the whole thing anywhere on the website.
If you do the whole,
it's
go ahead.
It's when you're done with the module and like you just go back to it, at the end it'll say results and it'll show you the whole report. Like go back to the module and it'll say pre-test, tutorial, post-test, and then right next to it is results.
Yeah.
And then you click that and that has the whole results for everything.
Thank you, Alexis.
You're welcome.
Yeah, thank you. I do have an example of what the module report looks like on here too. I'll show you real fast. So it'll say module report on it. It'll tell what module you did, and it'll say, all your results here at the top. And it'll talk about your lesson history and see, here's the total time. So I don't want to see anything that says 50 minutes or 46 minutes. It has to be at least an hour. So make sure you have spent an hour in it. And it's just, sometimes it's more than one page, but anyway, it'll go through all of that. So that's what I need. So anytime you see on your syllabus that you have a module that's due, that's what I'm talking about. So all you do is you do the module, you spend an hour in it, you print out this report, and then you send that to me, or you save it and send it to me. Okay?
So Ms. Silk, you're not looking for a final score on the post-test?
No. Obviously, I would love if everyone could get 100%, but I mean, I'm not requiring a specific score on the post-test for this. Okay. All right, let's see what's left to go over here. All right. So we've talked about the module, we've talked about the assessments, we talked a little bit about the proctored exam. Let's see what else. Oh, on here on the addendum it says, if you're repeating this course, you cannot turn in your ATI assignments as being done with an old date on them. So for you to receive credit, you must have a current date from this term showing that you've redone the material. Failure to do so will result in a 0 for the assignment, because I've had 3 million people try to do that. So you have to redo stuff. I get that maybe you're sick of doing the same thing or whatever, but you're not perfect. There's a reason that you need to do this again. So make sure that you redo those. Okay. Here's that thing about the templates. Here's the thing about the proctored assessment. We talked about math already. We talked about the care plan. With tests, anytime we have a test, we'll do that at the beginning of class. So we'll get that done at the beginning, and then we'll do content after that. With remediation for tests, you have to remediate with me if you have a 75% or lower on a test. So I'll have office hours, and you see I have office hours right after class. So generally we'll probably be able to get that knocked out right off the bat. So remediation typically will only be for test 1 and 2. Test 3 you see is like right at the end of the term, so there's no way I will have time to remediate with you for that. So I apologize, but just the way that it is, there's no time for me to be able to do that. All right, so that's the addendum. I think if there's anything else before we go on into our content. Okay. Oh, let me show you guys this too. Okay, so for those of you who are taking the class again, or maybe you were in a different cohort for some reason, I put the ATI product ID thing here on the announcements. You will need to change that. You'll have to go in here and do what this memo says to be able to get at all of the products that you're supposed to have. So like if you weren't with this cohort before, you need to make sure you fix that on your ATI. And it tells you step by step what to do in this memo thing I have attached here. So make sure you take a look at that. I think that's everything for the most part. Do you guys, can you think of anything you have a question about? And obviously, if you come up with something, just email me. It's not a big deal.
So for the modules, we can turn in a little early if we can get to them and just do them, right?
Yeah, that's fine.
Okay. And I know you were saying something earlier about I think it was the care plan that was the only assignment that's due midnight. I was having problem. I had sent you an email earlier trying to get into class, so I didn't get the due dates. Are they before class on the day of? Like, is that how that works, or earlier?
So for everything that we have due, other than the care plan, you need to turn it in before class.
Okay.
So like if we are in class at 8:30 and you turn it in at 8:31, it's late.
Okay.
So everything needs to be due before class. So the care plan's the only thing that I will accept by midnight the day of.
Okay. And the modules, can we email that to you once we do that, or is there somewhere in Canvas we can put that?
There should be drop boxes for everything on Canvas.
All right.
If for some reason you don't see one, just email me and tell me that so I can fix it.
Okay.
I tried to make sure everything had a drop box, so if for some reason I missed one, just tell me.
Okay.
I was getting too many stuff like that in my email the one term, and my email was so full I constantly had to empty everything. It was just getting ridiculous. So, okay, so let's get into our content. We'll do some pre-op stuff. So everyone feel okay so far?
So far.
Okay, good. Let's see. Let me open up this PowerPoint so everyone can see it. Okay, so pre-op stuff. All right, I do want to tell you that, you know, everything that we go over, usually there's kind of a corresponding chapter in your Med-Surg ATI book with everything. So like for this pre-op stuff, chapter 95 in your Med-Surg ATI book would kind of go along with that. So just so you know, you can take a look at that. All right, so this first slide just talks about how surgical patients have changed over the years. And, you know, years ago when I first became a nurse, when we would get patients, you know, from surgery, they were a lot less sick than they are now. Like people, you know, wait forever to come into the hospital to get, you know, anything taken care of now. A lot of the times it's because of cost of care, you know, because they can't afford anything, or maybe they don't have insurance. And, you know, it could be other reasons too, but just the acuity of patients is totally different than it used to be. So that means as a surgical nurse, you have to be very careful and really good with your assessment to make sure that you're having their needs met. So there's a few different definitions that I want you guys to write down. So what's the difference between major surgery and minor surgery? Does anyone have a thought?
Major affects more than one body system.
Okay. Anything else? Okay. Oh, go ahead if someone was going to say something.
I was going to say minor poses little risk to life.
Yeah, exactly. So when we talk minor surgery, this could be like, you know, years ago I had surgery on my one toe because I had like an ingrown toenail or something stupid like that. So that would be minor surgery. Minor surgery, like she said, presents little risk to life. Usually it involves only one body system, and it's not involved with cutting into a major body cavity. So like, you know, my toe, that's not a major body cavity, so that would be minor surgery. When we talk major surgery, this is going to involve a risk to life. And usually you have more than one body system that's involved, and you have to cut into a major body cavity. So like, for example, you know, open heart surgery, of course, would be a major surgery. Even like any kind of surgery where they cut into your body cavity, like, you know, appendicitis even, that would be a major surgery. You know, lung surgery where they have to, like, you know, take part of your lung out for cancer, that would be a major surgery. Okay, when
You
we
said
talk,
minor, I'm sorry.
oh, go
You
ahead.
said minor is like not going into a major cavity.
Correct.
And what else did you say?
So minor surgery presents little risk to life. It involves only one body system, and it's not involved into cutting into a major body cavity.
Okay, thank you.
Okay, so then we need to talk about the phases of surgery. So there is kind of a catch-all thing, which is called perioperative phase. Perioperative includes every one of the phases. So pre-op, intra-op, post-op, that's all perioperative care. So when we talk about pre-op, this begins when the decision to proceed with surgery is made, and it ends with transfer of the patient into the operating room. So like, you could be at your doctor's office and they could be talking about surgery with you, and then you decide, yeah, I think I do want to do that. And the minute you say yes, that's the beginning of the pre-op period. And then it ends when you go into the operating room. So it's kind of a longer period of time. Intra-op begins when you get into the operating room, and it ends when you go to the recovery room. So that's kind of a shorter period of time. And then the post-op phase is kind of long as well. So it begins with the admission of the patient to the recovery room, and it ends with the follow-up evaluation in the clinical setting or at home. So typically when people get discharged from the hospital, they typically will have a follow-up appointment with their physician, like maybe 2 weeks later or something. So that can be kind of a long period of time, you know, or maybe it is when the home health nurse comes to visit them, you know, so that would be the end of the post-op phase right there. Okay, so we also have some surgical classifications, and this is kind of important to be able to tell the difference between some of these things. So diagnostic surgery. So this type of surgery is going to be done to help facilitate a diagnosis of something. So a good example of this would be a biopsy. So if they do a surgery to biopsy something, that is going to help them make a decision on what to do next for treatment. Because if someone has cancer, because, you know, the biopsy shows they have cancer, then you're going to decide what to do from there. But if they don't have it, then that's going to change what you do. Another example of diagnostic surgery would be laparoscopic surgery or exploratory lap. So like, say someone comes in and you've done all these different tests and things and you just can't figure out what's wrong with them. So the last thing would be to do an exploratory lab. Like maybe they came in with this crazy abdominal pain and they have all these weird symptoms and you've done all of these different tests, but you just can't figure out what's wrong. But you know there's something. So you would go in and do this exploratory laparotomy where they go in and they can open this person up and they can figure out what's wrong by seeing because they open it up. So that's diagnostic. Curative surgery is where you actually fix whatever the problem is. So an example of this would be appendicitis. So if someone has an inflamed appendix, the only thing to do is take it out. You're not going to leave it in. You're not going to do any other type of treatment. So when you take it out, that fixes the problem. There's no other issue after that. Other things would be maybe excision of a tumor, like trying to think of a good one for that. Certain tumors, like when they take them out, that fixes it. You know, maybe it's like a benign tumor and it's pushing on something and causing you pain. If they take that out, that fixes the problem. So you don't have that problem anymore. So it's curative. Okay, reconstructive surgery. This is where they restore function or normal appearance by remaking defective organs or parts. So some examples of that would be congenital defects, like maybe someone has cleft lip or cleft palate, and they do a surgery to kind of reconstruct maybe their lips or something, or their mouth. That totally is reconstructive, and when they're done, they look normal instead of abnormal. If someone has breast cancer and they have to get their breast removed and they have to do reconstructive surgery to give them a breast back, that's a mammoplasty, so that would be reconstructive as well. Okay, cosmetic surgery. This is where they do like plastic surgery type stuff. So maybe they do a facelift or a rhinoplasty or a tummy tuck. So it's just to improve the person's appearance, and it doesn't really like help with any kind of other way. It's just about appearance. And then palliative surgery. So palliative surgery is to relieve symptoms or improve quality of life, usually in patients with an incurable illness. So here's a really good example. I have like a real life one. So I used to work in an ear, nose, and throat doctor's office a long time ago, and we had this guy that came in that had a tumor that was growing in his nose, and he was worried that it was cancer, but he left it go forever because he didn't want someone to say that it was cancer. He was so worried about hearing that diagnosis that he just left it go and didn't come in. So the reason he finally came in is because this thing got so big that he couldn't breathe anymore. So when we looked at him, we were taken aback because this thing was huge. It like deformed his nose and half his face. It was so big. So we knew it was bad just by looking at him without even doing any kind of testing. You could tell. But the surgeon went in and did surgery, took the tumor out. But the only reason we did it was because it was for comfort for this guy, so he could breathe. When we did testing on the tumor was a really aggressive cancer, and we knew it was going to grow back, and we told this guy, but we still did the surgery anyway to give him some quality of life so he could breathe, right? So what ended up happening with this guy is the tumor grew back and it killed him. And he was only probably 40s or 50s. He was young. So it was really sad.
I have a question. Can you go back to the last slide one more time? I just have that last thing to write. Thank you. Thank you.
Okay, so another type of classification for surgery would be rehabilitative surgery. So this is where they restore something to its original state. So this would be like your orthopedic kind of surgeries where they do a total hip replacement or a total knee. when they do that, they totally put, they take the disease stuff out and put new stuff in. So it's totally new. So like now this person has no problems with moving that joint. All right, here's another thing that's kind of important. So how urgent is surgery? So when we say emergent, we're saying that it requires immediate attention. The disorder can be life-threatening. So this person should be taken to surgery without delay. And some examples of this. Anytime you see a question where someone's bleeding uncontrollably, like they're having a hard time getting control of that bleeding, that's always emergent. If, you know, someone had a gunshot or stab wound, or they had a fractured skull, or extensive burns, or a bladder or intestinal obstruction, that would be considered emergent. Urgent is different. So the patient requires prompt attention, but usually you can wait about 24 to 30 hours to be able to do surgery. So it's not something you have to do right now. So some examples of that would be an acute gallbladder infection, or a kidney, or like kidney stones or something like that, where maybe someone has a kidney stone that's blocking something. That would be something that would be urgent. Required surgery, this means that this person can plan within a few weeks or months to have the surgery. So typically this would be things like a thyroid disorder where they're taking your thyroid out, or cataract surgery, or maybe that BPH surgery where they work on your prostate for older men. And then elective surgery is where failure to have the surgery is not catastrophic. So if you decided not to do it, you'd be okay. So typically this type of surgery would be things like repairing scars, or a simple hernia, or maybe even a vaginal repair. And then optional surgery is something that's just personal preference. So this typically would be like cosmetic surgery. You know, like if you're going to have a facelift or a rhinoplasty or something like that. Okay, so now that we've talked about all those different types of surgery, we need to talk about kind of what happens in this pre-op phase. So once this person decides that they want surgery, we have to do some things with pre-op testing and like that pre-op appointment typically that they have to go to. So what do you think? I don't know if any of you have ever had, has anyone in here had surgery before? So what do you remember about when you had surgery? Did you have to go for a pre-op appointment?
It was appendicitis, so it was emergent.
Okay. How about anyone else?
Yes.
I had to get my tonsils taken out. I have to do a pre-op, and I actually went to my pre-op and I had the flu. Oh, it was horrible. And I had to wait. They delayed my appointment. And then I went to another pre-op, and then everything was fine. And then they let me get my surgery. I was just getting my tonsils taken out though. And that was worse than having a baby. So if anybody ever have to do it while they're grown, do not do it. Just stick it out.
Yeah, I hear that is rough when you're older, definitely. Okay, so what I want you guys to think about is what kinds of things do they do at a pre-op appointment? What kinds of things do they ask you about?
Medications.
Yeah, they want to know what medications you're on. And what is important for us to specifically pay attention to with medications?
Like herbals, like and like interactions, like contraindications and stuff like that.
Definitely. So I don't know if you guys know a whole lot about herbals, but it seems like every herbal under the sun has some kind of interaction with something else. So it either makes you bleed more or it causes you to be like really sleepy when it's mixed with anesthesia or like a lot of crazy stuff. So it's really important that they tell us everything that they're on. What other medications would we want to pay special attention to?
Blood thinners.
Blood thinners?
Yes, blood thinners. So a lot of times when people are on a blood thinner, they tell you to stop it so many days before surgery, right? So that's definitely something we would want to ask about. And then a couple other ones that maybe you wouldn't think about would be when people are on tranquilizers or steroids. Those would be things to watch for as well. So steroids can like mess with your blood sugar and they can cause all kinds of issues. So that's really important. And then tranquilizers, that can interact with stuff that they might be taking for surgery. So you would want to watch with that as well. Okay, what else would we be seeing them ask in a pre-op appointment?
Allergies.
Allergies, for sure. Anything else?
Diet restrictions and any prior surgeries.
Okay, for sure. Yeah, we want to know their surgery history because if they've had issues before with anything, that's really important for them to tell us now so that everyone's on the same page. You know, if I've had issues with anesthesia, I would want to let my anesthesia provider know this. What else would we want to be concerned about?
What about family history? Like, would they ask about family history, or like if your mom had a history of like, I don't know. Never mind.
No, that's fine. They may ask something like that, sure.
Depending on the surgery.
Yeah, exactly. So certain surgeries, like if it's not really super serious, like if it's just a tonsillectomy or something, then maybe they may not ask as much. But if it's a more serious surgery, they may ask you more. So you're right. So other things that we're going to be concerned about, we want to talk to them about if they're having any kind of discomfort or pain that day of the pre-op appointment. So we're going to get specifics about that. We want to ask them if they have family or significant others that are going to be able to help them after the surgery. Do they have any kind of religious affiliation? Because if they have, you know, specific wants or needs, you know, as far as that goes, we need to know that right off the bat. We also want to know what their perception of the illness and impending surgery is. We want to make sure they have a good understanding of what's happening. And then we want to see if they have any kind of psychosocial needs. Do they have a problem with anxiety, or they're really nervous about their surgery? Because if that's the case, then maybe they need, you know, some medications to help calm them down. Also, part of the pre-op appointment is going to be, you know, drawing blood and getting certain testing things done, right? So again, it's going to be different compared to which type of surgery you're having. If it's a more serious surgery, they're going to do more. If it's not as serious, they may not do that much. Or, you know, maybe you're just a kid and you're getting surgery, so maybe they're not going to do as much as well. If you don't have a whole lot of history of a bunch of things wrong, then they're not going to go as in depth. So some of the blood work that we might see would be a CBC. They may do an electrolyte level, like a BMP or something like that. Coagulation studies. They may also look at their kidney function, so serum creatinine and their BUN. They're going to pay attention to blood sugars. So if someone has a history of diabetes, they're definitely going to be watching that. They're probably going to do a urinalysis. And especially if you're a woman having surgery, they're going to do a pregnancy test unless you're not able to get pregnant anymore. And like my daughter had surgery a few years ago, and she was just a teenager, but they still did a pregnancy test, because that's important to know before you take someone into surgery. So urinalysis. And then chest x-ray, sometimes that would be something you would see done. And then usually if you're older than 40 or if you have a history of something, they're going to do an EKG for adults. Okay, so that would cover kind of what you would do in the pre-op appointment. Other things that you may be doing would be doing some education about the surgery and like things that they could do to prevent problems. So some of the pre-op teaching would include things like deep breathing and coughing exercises. You could talk about how important it is to get up quickly after surgery, not wait all day and to get up. You need to get up pretty soon after you come back from surgery. Turning and repositioning, how important that is. You're also going to talk to them about their pain administration policy. So like if you anticipate that they're going to be on a PCA pump after surgery for whatever they're having done, you would talk to them about that and how to use that. You would also make it clear to them that they need to ask for pain medicine and that they shouldn't just expect their nurse just to come medicate them every so often. They have to ask for it. If they have any kind of adjunct equipment that is going to be used with them, after their surgery, like, I don't know, maybe they're going to be on a ventilator after surgery. You would talk to them about that and things to expect. Maybe you would give them a spirometer at the pre-op appointment and show them how to use it. It's always better to do it when you're not having pain and do it correctly at that point so you know afterwards how to do it right. You would also talk about the NPO policy and why it's important to not have anything to eat or drink after midnight. And then sometimes, you would mention like the anti-embolism stockings or the pneumatic cuffs for their legs and why we use those and why those are important. What do you guys think is different about teaching like a kid who is going to get ready to have surgery compared to an adult? How would you have to approach that?
Would you have to explain it different?
Yeah, you have to use terms that a child will understand, so you would be able to use like basic medical terms that an adult could understand.
Definitely.
Attention time. You got to make sure that they're engaged, so the teaching has to be accordant with that.
Okay.
Using visuals and concrete terms to understand.
Yeah.
And I think too, you will also have to, like, for a child, maybe they might be a little more anxious than an adult would. So I think you would have to also like deal with that more with kids as opposed to adults.
Yeah. So I remember years ago, I had my tonsils out when I was like really young, and my parents weren't allowed to go with me. They weren't allowed to be with me at that time, before I went to surgery. So I just remember I have this worst memory of being rolled down the hall on this gurney, and I'm screaming for my mom and crying, and they wouldn't let me be anywhere near them or see them. And that's different now.
Right,
now they let parents be with you all the way up until you go into the OR. It's like really nice. So just remember, it's scary for kids. So you have to be really cognizant of what they're thinking and their views about everything. So some of the things you need to worry about would be, you need to teach around their developmental level. or their previous experience. So if you have a toddler, they're going to be different compared to a teenager. You know, you have to teach according to where they're at in life. A lot of times, you know, like say my kids had ear tubes placed when they were little. So when we went to the hospital for that, which if you know anything about ear tubes, it's like a really short little procedure, but they actually will put you to sleep for that when you're a kid because there's no way you would hold still for it in the office. And so if you did it in the office, it'd be just like 10, 15 minutes and you'd be done. But anyway, when my kids had that done, they had a child life specialist that would come to the room and they would talk to the kid and they would show them what the ear tube looked like. They actually had an example of one and they got to see it, and then they weren't so scared because they saw what it was, you know? So stuff like that would be good. Sometimes role playing to explain procedures or allowing a child to do a return demonstration about something. Another thing in the past with my kids, when they had surgery, they would ask them, like my daughter had her wrist operated on, and she, you know, she was a teenager when she had this done, but she's really like queasy about everything, and she didn't want to have them put an IV in her when she was awake because it freaked her out. So they let her decide about that, and they said, okay, that's fine. We'll put you asleep with a mask first, and then we'll do all of that. So they let her like put stuff on her mask that was pleasing to her. You know, they put like chapstick that's flavored on there so that she smells that when she gets put to sleep and it calms her down. So stuff like that, you know, is kind of what they would do. Also, you want to plan to teach when kids are more receptive to learning. So like if someone's in pain or they're having an issue some other way, it's not a good time to teach at that point. They have to be receptive to you at the time. You want to introduce anxiety-provoking information last because increased anxiety decreases comprehension. And always include the parents in the teaching process. That's very important. Okay, so when we talk about day of surgery then, when someone comes in, they are in the pre-op area. Typically they have like a holding area that they keep you in before you go into surgery. There's certain things that nurse is responsible for doing with the patient before they go into surgery. So can you think of anything in particular that they might do?
One of the first things you're going to do is look at the chart, make sure I identify the patient.
Definitely. Why is that so important?
Don't want to do the wrong thing to the wrong patient.
Exactly. So
and you also want to make sure they don't have any allergies, especially like a latex allergy.
Yeah, yeah. So there's something called a timeout that, I don't know if you guys are familiar with that term or not, but they do a timeout before they do any type of procedure with the patient. So the nurse in that area might be responsible for that. So this person would make sure they have the right patient, they know they're doing the right procedure, all of that, the whole 9 yards. Believe it or not, years ago, they used to have all kinds of issues with that, where they would have the wrong patient that they would take into surgery, and they would take off their limb or something, and it wasn't the right patient. Can you imagine? So lots of crazy stuff has happened in the past. So we want to keep our patient as safe as possible. So that's definitely important. What else would you do in this area?
Vitals and prep.
Okay, so you would want a baseline set of vitals to put on the chart when they go to surgery, sure.
You are also, go ahead.
I would say calm and reassure the patient, walk them through what the procedure is.
Okay. Yeah, and it varies depending on your patient. Sometimes patients are really receptive to that and sometimes they're not. I've had people in the past who have been super nervous and they don't want to hear anything about the surgery because it's going to amp up their anxiety even more. So other people want to know about what to expect, and it makes them feel better. So it just depends on your patient and how much you say to them. All right, some other things that you might be doing in this area. So sometimes, like again with my daughter with her wrist surgery she had a while ago, in that area, it was really nice. I don't know if you guys have been to Children's lately, where that new part that they redid. Wow. But anyway, in that area, she was sitting in this room for a while before they took her to surgery, and had a TV and all this stuff. And they just like dimmed the lights, and they made sure she was nice and warm, and like she just was nice and calm. You know, if she wanted to, she could fall asleep. That was totally fine. So anything you can do to just like relax this person, that's what you want to do. Other things that we might be concerned about, in the book, it talks about physical preparation of the client for surgery. It kind of depends on the surgery on exactly what you have to do. As far as skin preparation, sometimes that's more done in the surgical suite once they get into the operating room, and sometimes it's done beforehand. So have you guys seen chlorhexidine wipes before? I don't know if you've ever seen those or not. So go ahead.
I was going to say I've seen them.
Okay. Chlorhexidine wipes, sometimes surgeons will want you to wash off with those in certain areas of your body before you go to surgery. So typically they'll tell you to do it the night before surgery and then the morning of. So you would do that, and then once you get into the OR, they actually clean you off even more. But this is just in preparation for surgery and to help prevent you getting infected with anything.
Yeah, but cleanse is something that is being used a lot too.
Yes, definitely. Also, sometimes they will do like a prep area of their skin. Like say you're going to get an abdominal incision for something. If like say you have a guy that you're doing surgery on and he's real hairy there, sometimes they'll have you get rid of some of the hair in preparation for the surgery. So they don't want you to shave per se. A lot of times they'll have clippers, because the shaving, you can get nicks and stuff from that, and you can get infected that way. So the clipping is just better. So sometimes they'll do that. Usually they do an area of prep that's longer and wider than the incision would be. So they do kind of a bigger area. Okay.
So is it true that they do like they'll draw like the lines on the person's body where they like need to cut, or is that something that they wait until they actually get into the surgical suite to do?
Yeah, typically they don't really draw the lines on you where they cut. So you know, sometimes they'll mark the site that they're working on. They'll do that before you go to the surgery. And as far as that goes, your responsibility as a nurse is not to do that for them, but to make sure that it's done. So like the surgeon would have to come to the room ahead of time, and they would talk to the patient and be like, which arm am I doing, or which leg am I doing? And the patient would verbally say it, and then they would mark it with the patient to say, yes, this is the site that we're doing. And so they have some kind of special marker thing that they use to like designate that's what's going on. Like with my daughter's wrist, they did that, you know. So when she was in that pre-op holding area, that's when the surgeon came in and did that with her. So that needs to be done before they go to the OR. It's the surgeon's responsibility to do that, but you would reach out to the surgeon if you didn't see them do that yet, you know, to say, hey, this still needs done. Okay, so the next few slides are just talking about different specifics about things we should watch with different types of populations. So like this one is about older adults. So older adults have a less physiologic reserve compared to younger people. So this means that their organs' ability to return back to normal after a disturbance in their equilibrium is less than a younger adult's. So they're more at risk for certain things. So respiratory and cardiac complications are really common with them. They tend to have less subcutaneous fat, which makes them more at risk for hypothermia after surgery. And they're more at risk for skin breakdown and skin issues because of their decreased ability to perspire, leading to dry, itchy skin that can become fragile. And with bariatric patients, we have a lot of bariatric patients anymore. So obesity is going to increase the risk and severity of complications associated with surgery. So wound infections are very common. Also problems with wound dehiscence where it opens up. And then also when they lay flat, they have a problem breathing because they're so big. And so this increases their risk of hypoventilation. So they tend to have a lot of respiratory complications after surgery. A lot of times they're very hard to intubate because they have like these short, thick necks. And so because of this, a lot of places now have an intubation team, like a special intubation team for people like this with special equipment. Also, people with disabilities. So special considerations need to be made about that. So if they need any kind of assistive devices during surgery or right before, like a hearing aid or something, you need to make sure they go down to surgery with that. You know, if they, if they have a hearing impairment, they're entitled by law to a sign interpreter or some kind of alternative communication system pre-op. Because if you can imagine, that'd be horrible, not being able to hear what people are trying to say to you and you're all nervous about your surgery. Excuse me. Whatever the disability, these factors need to be clearly identified in the pre-op period and communicated to the appropriate people. I think it would be super horrible if you didn't speak English, and you had to go for surgery. So interpreters have to be in place so the patient understands what's going on. I don't know, you guys, maybe some of you work at SUMA. I don't know if anyone does, but they have that blue phone system that they use for interpreters. So like if you had someone who didn't speak English, you could send that phone system down with them and they would be able to call up an interpreter right away and translate for them.
Excuse me.
Yes.
During surgery, please, because I haven't had any of all these things. I don't even have any medical history. Apart from this stupid nursing assistant, must everybody going through surgery be put to sleep before the surgery is done?
It depends on the surgery. So if they are going to have something pretty extreme done, then yes, they're going to be put to sleep. That's called general surgery, where they put them under a general anesthetic. With that, they don't necessarily put them to sleep before they go into the OR. They usually do it right when they get in there.
Okay.
Other things, it varies. Maybe there's other types of anesthesia that they may use for other people. So we'll talk about that more in the intra-op stuff about the anesthesias.
Okay.
Okay?
Yep.
All right, so now we're at informed consent. So this is something that's an important concept that you need to really pay attention to. So with informed consent, this is the patient's autonomous decision about whether to undergo a surgical procedure. So your role as a nurse is not to get informed consent at all. It's the surgeon's job to get informed consent. What this means is that the surgeon is going to go into the room at the bedside with the patient, and they're going to say, hey, I think you need surgery. this is the type of surgery I think we need to do. This is all that's involved, and he would talk about everything involved with the surgery. Then he would say, if you don't do this surgery, these are the risks that could happen to you. You know, this could happen, or this could happen. And then they also are supposed to be able to tell you some alternatives. If you decided not to do the surgery, what could you do instead? You know, so those are some of the things that they would talk to you about. And then if the patient decided, yes, I want to have the surgery, they would sign right then and there with the surgeon. Your responsibility as a nurse is to be the witness to their signature. So maybe you would be in the room with them when they're talking about this, and then once the patient decided to sign, you would sign underneath them, saying that you're the witness to them. There is a spot on the consent form called the physician attestation. And at the ones at SUMA, I know there was a real small little box about it. So on that is where the physician marks on there and signs to say that, yes, I did talk to the patient about all of these things. And that's what the physician attestation is, that yes, I've talked to them about risks, I've talked to them about the surgery and their alternatives and everything. So when you send a patient to surgery and they have a consent form that goes with them, if you don't have that physician attestation filled out, then they can't go through with the surgery. That has to be filled out before they can have it. So in a perfect world, you would have that filled out right then and there when they sign it, but it doesn't always work out that way. So
what is the name of that again?
Physician attestation. So when you're getting consent from someone, consent has to be freely given. You can never coerce someone into having something done. So some other things that you need to know about this, for someone to be able to give consent, they have to be at least 18 years old or emancipated. What's it mean to be emancipated from your parents?
That you like can make your own decisions.
Yeah, and it's actually like a court
decision. You're like legally separated from your parents.
Correct. And it's a court thing, you know, so you have documentation that you're the one that can make your decisions. So 18 years old or emancipated, you have to be mentally capable of understanding the risks, the reason, and options for surgery and anesthesia. And if they aren't able to sign for themselves, they must have a legal guardian or a power of attorney that can do this for them. So if you're ever in that situation where you have someone who's not able to sign for themselves, sorry, you would talk to the power of attorney and have them do it. So like say they were there with you and they actually signed the consent, you would have to put power of attorney next to their name so you know that's who it is. And then if you talk to them on the phone, you could get consent on the phone, but you have to have 2 RNs who listen to this on the phone. So like maybe I am talking to this person and I'm saying, yeah, Dr. Espinal wants to do this, this, and this for your dad tomorrow. Are you good with this? And they'll say, yes, I'm good with it. And then you'll be like, okay, can you hold on a second? I'm going to put another nurse on the phone so they can hear you say the same thing. And then the next person would ask them the same stuff. And then once you get off the phone, you would sign the power of attorney's name and put power of attorney. And then you would put your name / the other nurse's name as the witness. And you would put telephone consent next to that. Okay, what happens if you have a minor, like a kid, who has to have surgery emergently because it's life-saving measures, you know, like they are really in dire need of surgery. If there's no one available to sign the consent, what are you supposed to do?
You have to have 2 physicians sign off on it, don't you?
No. So if it's documented that this is emergent type of surgery, like with all of their things that they found out that they absolutely have to go, this kid can go to surgery regardless. The thing is, you have to make every opportunity to contact the patient's family, like their parents and everyone who would be able to make the decision. Like you have to have that documented, that you've called 3 million times, that you've texted or you've emailed or whatever. You've done everything you can to try and contact these people. So in a legal situation, you're never going to get, anything said bad about you for taking this person to surgery. That's totally okay to still take them. Okay, and then also I do want to mention, and I don't have a test question about this, but I just want to mention this real quick. With consents, sometimes like when you go in for a pre-op appointment, I've seen people have a consent signed at that point, and sometimes your pre-op appointment is a while before your surgery even. So how long is a consent form good for?
6 months.
It's going to be whatever your facility sets.
Okay.
So it's going to vary depending on the facility. But yeah, so like I remember my kids, I took them in for a pre-op appointment for something, and then they didn't have surgery for a few days after that. But then once we went in, the consent was fine. I didn't have to sign another one. It was fine. Where some facilities are different, and they'll say, no, you have to sign it that day, or it's only good for 3 days or whatever. So you do whatever your facility says. It's according to them. All right. So anyway, the rest of this is just going over some other little tidbits about, pre-op things that you need to be aware of. So with the pre-op assessment, when they come to you and right before they go to surgery, you have to do a good assessment on them to make sure everything is okay. So you do a health history, the physical exam. If they didn't have a pre-op appointment, maybe you have to do it all that day. You make sure you have vital signs, so you have that baseline to compare them to afterwards. If someone never did vital signs on someone before surgery, it's very hard to know what's normal for them afterwards, because you don't have that understanding of this person yet, So really, if you're in the pre-op area, this is like the baseline for you getting to know this patient. So, hey, I have listened to their lungs and they sounded like this. When I talked to them, they were alert-oriented ×3. This is what their vitals look like. This is what their weight was. Like, you do all of that. Because when this person is transferred to the different places, to intra-op and post-op, it may be different nurses completely taking care of them, and they're not going to know anything about this person. So they rely on this pre-op information so that they can know what's normal for this person. Okay? Let's see. Oh, another thing on this slide here, towards the bottom, the second to the last thing. So when we talk about allergies, people who are allergic to kiwi, avocado, or banana can be more at risk for latex allergies. So that's something to remember. A latex allergy can manifest as a rash, it can manifest as asthma, or even full-blown anaphylactic shock. So you have to be really careful about anything with latex. And if you know ahead of time that this person is allergic to latex, then you can alert the OR of that. And there's a lot of things that aren't, are latex free now that they can use. Okay, other things that are kind of important to know. When we talk about drugs and alcohol, ingesting even a moderate amount of alcohol prior to surgery can weaken a patient's immune system, and it increases their likelihood of developing post-op complications. So drugs and alcohol can also impede the effectiveness of some of the medications they might be getting. People with chronic alcoholism often suffer from malnutrition and other metabolic imbalances that will increase the surgical risk. So in patients who are alcohol dependent, alcohol withdrawal syndrome may be anticipated 2 to 4 days after their last drink. And it's associated with a significant mortality rate when it occurs post-op. So people aren't always forthcoming about how much they drink. Some people are, some people aren't, you know. So maybe they tell you they don't do anything, but you can tell something's not right with them, and you suspect that they do. But yeah, so it's really important to try and get that information, though, because you can see it can really cause a lot of problems after surgery. Also, people who smoke are more likely to experience poor wound healing. They can get pneumonia, and they can also get blood clots really easily. So those are some important things to know. Okay, so herbal medications like ginkgo biloba, ginseng, feverfew, all of those things should be stopped 2 weeks before the surgery to prevent hemorrhage and adverse effects of anesthesia. And then aspirin should be stopped 7 to 10 days before surgery because of the increased risk of bleeding as well. So sometimes there's a question on whether you can give people certain medications before they go to surgery. So things that are still okay to be taking the day of surgery would be things like diabetes meds, some antihypertensive meds, meds for glaucoma, seizure drugs. Usually like pulmonary drugs like inhalers and things, that's fine to take. That's not going to hurt anything. And then a lot of times cardiac drugs too. So typically you can give most everything except for a few things. Now, as far as the diabetic meds go, you know, if they have just like an oral pill, chances are that may not be what you would give. But if they have insulin, typically you're going to give insulin before they go, because you don't want to have their blood sugar be all out of whack during surgery. That's, you know, so if you're ever unsure about that as a nurse, you always call your doctor and ask, hey, what do you like? What would you want me to do about this? This was what their blood sugar was. Or do you want me to hold this because their blood pressure was this? You know, always ask. That's, you know, no one's ever going to fault you for that. Okay, so here's some pre-op nursing interventions that we kind of do to help prevent problems afterwards. So if you think about pretty much every surgery is going to have the same type of complications afterwards. So like we're always worried about things like pneumonia, we're worried about blood clots, you know, things along those lines. So we're worried about pressure ulcers and pain management and all that kind of stuff. So the things that we do and we educate about are going to be things to help prevent those things from happening. So we give both verbal and written explanation of everything. So after surgery, we want the patient to be sitting upright, right? We want them to be in like a Fowler's or a semi-Fowler's position to enhance their lung expansion. After practicing deep breathing, instruct the patient to breathe deeply several times, and then exhale through their mouth, take a short breath, and then cough deeply. So when we talk about coughing and deep breathing, that's what we do. Deep breathing before coughing stimulates the cough reflex. We also want to talk about, like if someone has abdominal surgery, we want to talk about how to splint the incision. So anytime they have to cough or sneeze, or even when they get up out of bed or something, or they go to move, they splint their incision with a pillow or a blanket that's rolled up or something like that. We want to educate about the difference between acute and chronic pain, so patients are able to tell the difference between the two. We want to talk about taking pain meds frequently through the initial post-op period, and then also talk about PCA pumps if they're going to have one. We want to talk to patients about early ambulation and why that's important. It's going to help improve circulation and prevent venous stasis and promote optimal respiratory function. And then it's also important for patients to do exercises after surgery, such as flexion and extension of their knee and hip joints, rotating their ankles, shoulder and elbow range of motion. And these things will help maintain muscle tone so that ambulation is easier, but also are done to decrease the chance of getting a DVT. All right, and then we kind of mentioned this earlier. How do you reduce anxiety and fear about surgery? You can tell patients that when they're going to see their family again, you can, offer to get them a spiritual advisor, like a pastor or something to talk to them before surgery. Or you can tell them about what to expect. And again, every patient is a little different, so you have to take your cues from your patient on whether that's going to be helpful or not. You want to maintain patient safety. So a lot of times people will get like a pre-op medication before they go to surgery. So if they do, they're going to be more at risk for falls after they get the pre-op med, because the pre-op med is going to relax them and it can cause them to be dizzy and lightheaded. So anytime after they get that pre-op med, they need to be helped back and forth to the bathroom. They cannot be getting up on their own. And then also, with the pre-op meds, back when we talked about consent forms, you would never want anyone to sign a consent form after they get pre-op meds. You always do that beforehand, so they're clear-headed. Okay, once they are ready to go to surgery, they have to be in a hospital gown. Their hair should be pulled back and put under a cap. Dentures are removed. Any body piercings or jewelry should be removed. Wedding ring is okay to be taped if you can't get it off. Other valuables should be given to the family to keep track of. Patients should urinate before going to the OR. If pre-op meds are given, the patient should be kept in bed with the side rails raised because their medication can cause lightheadedness, like I was just saying. There is something called a pre-op checklist that usually most hospitals use, and it's put on the front of the chart along with the consent form. And on this pre-op checklist, it has everything that you need to know. So like it'll ask things like, was the consent signed? You can mark yes. Were pre-op labs done? Yes, here they are. Here's the results. Do they have family that's waiting in the waiting room? Yes, this is how you get a hold of them, So there's all kinds of things on there, and it just kind of walks you through all the important things you need to know. So down at the bottom here, it says patient may be transported to the pre-op holding area where they should have their identity verified, the surgical procedure, and the surgical site to maintain their safety. So that's like that timeout I was telling you about, to make sure that they have the right patient, the right procedure, all that kind of stuff. And the last slide here. So we also need to think about the family members. They're always like really nervous when their patient or their loved one is in surgery. So you need to tell family members to not judge the seriousness of the operation by the length of time. So like, for example, a while ago, my dad had surgery and I was waiting with my mom in the waiting room. And this was at Trumbull Memorial Hospital in Warren. So we were sitting there, and they're a little bit behind in the times there. They're not very, I don't know, maybe they're getting better now. But so at most places, there is someone who kind of keeps you updated. And usually they have like a TV screen where you can watch and see, oh, now my patient is in the OR. Now they're in the recovery room. It tells you where they're at whenever things are going on. Well, they don't have that at this place. So my mom was freaking out because we left my dad forever ago, and now she's looking at her watch and going, geez, why is he not out? Something must be wrong. And so she's crying and all upset. And I go up and ask this person, and they're like, oh, no, he didn't even leave the, he didn't even go into surgery when you guys thought he did. They had some kind of person that was pushed ahead of him. So he was sitting there forever before he even went into the OR. So, you know, you have to make sure people understand that sometimes things can happen. Maybe there's a emergency, you know, that happens and someone else is a little bit more emergent and they get pushed ahead of that person. You know, sometimes things get delayed. There's a lot that can happen. So just tell them not to be worried that way. Try to inform family members of what to expect when they go to see their loved one in the recovery room after surgery. A lot of times they're hooked to a lot of different tubes and devices, and that might freak them out. So just kind of make sure they're aware of that. It's the surgeon's responsibility to relay any kind of surgical findings and prognosis to the family and patient, not the nurse. So if you're, you know, family members of the patient that you're taking care of are asking you about that, you refer them to the physician. It's not your place to say anything, whether you know about it or not. Okay, so that's all I'm going to go over today because it's been a long morning. So next time we meet on Thursday, just expect we're going to go over the other two PowerPoints, and I'll mention a little bit about pain that day as well, and we're going to also do a little bit of math. So I will have some kind of practice math worksheet or something that I give you guys to do. So, questions?
When is the math test? When is the math test? When is the math test?
Next week on Tuesday, I believe.
Okay. How many times are we taking it twice or is it just once?
Yeah, it's just like always. So you have up to 2 times to take it.
Oh, okay.
And you said that you'll have a practice right on Thursday.
Yeah, we're gonna do some practice with it on Thursday.
Okay, thank you.
And is it right at like the start of class or at the end?
What, the math test or my practicing?
Yes, the math test.
The math test will be at the beginning of class when we take it.
Okay. Thank you.
Uh-huh. All right, so any of you who have clinical coming up the rest of the week, make sure you go do your access codes, you know, with the bookstore like that, and make sure you can get into your stuff like you're supposed to. If you're still having issues, I showed you where you can find, you know, contact information for technical support for all of that. So make sure you call people about it today. Okay. All right. I will get off here with you guys.
Thank you.
See you Thursday. Okay.
Thank you.
Thank you, Ms. Silk.
Sure.
Bye.